Ladies and gentlemen, esteemed guests, Sabah al Khair, good morning, and welcome to today's event titled From Self-Efficacy and Knowledge to Sustainability, Advancing Refugee and Migrant Health in the MENA region. This event is dedicated to a project that was led by the Refugee and Migrant Health Program at the Global Health Institute at the American University of Beirut. My name is Nadine Sabra. I'm a program manager at the Global Health Institute and happy to be your master of ceremony for this event. To open the day, we are pleased to begin with remarks from the President of the American University of Beirut, President Fadlu Khouri.
Good morning. You sound pretty sleepy. I'll try again. Good morning.
Good morning.
Okay, better. Good morning, colleagues, partners, and friends. Today's event is a moment of reflection, reckoning, and renewal. As we gather to find the observations and findings, to share them of the SEEK project, to reflect on what we've worked on, what you've worked on, we have to take an honest look at the challenges which seem to become more and more formidable by the day and by the year. We're constantly reminded that refugee health is not a temporary assignment and not a transient problem, but rather one of the defining humanitarian crises of our time. And our response and our mobilization of effective imperatives must be equally enduring and thoughtful. The SEEK project, Self-Efficacy and Knowledge, embodies a principle that's simple but consequential. Access to sexual and reproductive health services is not a privilege, but a right. As we found out in the last few weeks, even in this country, it can be a controversial right. But especially for young women and adolescent girls displaced by conflict, these services are lifelines and they're worth standing up and fighting for. By the end of April 2025, there were more than 122 million forcibly displaced people worldwide, up from 120 million just a year earlier, according to UNHCR's Global Trends report. The number of refugees and others forced to flee has been rising steadily for a decade, with women and girls making up about half of this population. Globally, over 60 million displaced women and girls, therefore, face heightened risks of early marriage, limited access to essential services, and they are disproportionately exposed to gender-based violence. In the Syrian crisis alone, more than 6 million individuals remain refugees, even today. And Lebanon hosts the highest number per capita. Around 1.5 million Syrian refugee women in Lebanon are particularly vulnerable to sexual violence, reproductive tract infections, and pregnancy complications, all compounded by poverty, displacement, and extremely limited access to health care. Too often, their basic needs go unmet, placing their health, their safety, and their dignity at constant risk. This project reminds us that health interventions have to be rooted in the lived experiences of those we serve. Adolescence is vulnerable terrain in any setting, but in the context of displacement and uncertainty, access to reproductive care becomes essential for safety, autonomy, and for basic human dignity. As we move forward, we have to ensure that the impact of SEEK doesn't end when the project cycle closes. These lessons learned and the community networks built must be rooted in national strategies, future research, and policy planning that becomes actual progress. Sustainability begins when successful interventions are scaled, adapted to several circumstances, and ultimately serve the many and not just the few. Today's event is therefore a model of thoughtful exchange, a chance to pause to acknowledge the obstacles, logistical hurdles, coordination gaps, funding uncertainties, and the difficulty of translating pilot success into long-term systems change. That kind of reflection, which has to be honest, sometimes brutally so, is vital because we often move too quickly in the humanitarian in global health fields to reflect thoroughly. We need to sometimes slow down and think about the impact and the sustainability of our interventions. However, real learning requires deliberation, and improvement demands dialogue. The Global Health Institute itself continues to be one of AUB's most responsive and compassionate centers of excellence. Its leadership in refugee health through the Refugee and Migrant Health Program, sustained research, frontline programming, and regional partnerships all have made a real difference in people's lives. So GHI's success comes with expertise and investment, yes, but equally from its willingness to partner broadly, to adapt quickly, and to listen broadly, especially in communities where trust is fragile and hard-earned. For that reason, I hope we can continue to institutionalize this kind of reflective convening within the GHI's major initiatives. Dissemination can't just be an add-on. It's central to how we understand and amplify our impact. As you will hear today, the barriers that refugee women and girls face in accessing sexual and reproductive health services are formidable. They're compounded by political fragility, economic stress, and systemic inequality. These are justice issues that perpetuate health issues. And we know that the root causes are the absence of social justices, but that doesn't allow us to pause to treat some of the fallout of these inequalities. Therefore, we can't afford to separate the research from the political and policy environments that shape outcomes. We also can't allow the great to be the enemy of the good. Sometimes solutions that make a major difference at a time have to be adopted in parallel with the long-term reforms that are necessary. One constant theme that emerges from SEEK is the need for collaboration. The project's success stems from the strength of its partnerships with ministries, with international agencies, with frontline community actors, with NGOs. Real collaboration is not transactional. It's co-owned, co-created, and it has to be action-oriented in these circumstances. Therefore, the spirit we have to carry forward in refugee health is a commitment to help shape coalitions that can actualize change and not just study the change necessary. I leave you with a sense of gratitude. Carried out in partnership with the World Health Organization, which itself is under enormous pressure as its funding streams are reduced, and generously supported by RHP, SEEK represents what we can accomplish when evidence, empathy, and shared purpose come together. The work it reflects is powerful, it's urgent, and it's deeply human. At AUB, we need to continue to be active participants in shaping a healthier, more just future. I want to thank you all for your commitment and hope you'll keep moving well into the future. Thank you.
Thank you, Dr. Khouri. While Dr. Shadi Saleh, founding director of the Global Health Institute, won't be able to make it today due to last-minute changes in his flight schedule, Ms. Noor Al-Arnaout, associate director of the Global Health Institute, will be delivering the remarks on his behalf.
Good morning, everyone. It's a great pleasure to welcome you here today on behalf of the Global Health Institute at the American University of Beirut. I'm stepping in here for our founding director, Dr. Shadi Saleh, who unfortunately could not be with us today due to delays in the flight. He sends his warmest regards and deepest appreciation to all of you. Being part of AUB, we at GHI hold a firm belief that our role does not end at the walls of the university. Dr. Khouri has always said that our role as AUB starts beyond the walls of this university. And so is our mission. It is to extend beyond into communities where we stand in service of those who need support the most. We are guided by this belief that real impact is not measured only by peer-reviewed publications or institutional milestones, but by how deeply we are able to touch the lives of underserved populations, of those who need our expertise and our support the most. This project, the SEEK project, which we are focusing on today, is one example of how at GHI we continue to bring research, evidence, and innovation directly to the ground to impact the lives of those who need support the most. Nowhere is this responsibility more urgent than in the context of Lebanon, a country grappling with overlapping crises and home to one of the largest per capita refugee population in the world. Syrian refugees, Palestinian refugees, and marginalized host communities continue to live in fragile conditions where access to essential services, and particularly health services, is often limited, especially in the realm of sexual and reproductive health. We know from both research and field engagement that refugee women and girls face a complex web of sexual and reproductive health services and needs, from inadequate access to antenatal care and family planning to increased risk of gender-based violence and psychosocial distress. These needs are not being adequately addressed by existing systems. There are structural barriers, financial hardship, legal status, and sociocultural dynamics that all contribute to the persistence of these gaps. And as the humanitarian attention fluctuates for the different crises that are happening, unfortunately, in the MENA region, these gaps risk becoming normalized. The SEEK project sought to challenge that normalization. In partnership with the World Health Organization, WHO, and with the support of ELRA, this initiative piloted an integrated, evidence-based, low-resource, low-intensity intervention package that addressed both psychosocial and sexual reproductive health needs among refugees and marginalized communities. Today marks the closing of the SEEK project, a unique initiative that aligns with GHI's mission and spirit. It is a moment to celebrate progress and reflect on lessons learned. But our intention today is not simply to mark the end of a successful implementation. This is not a closing ceremony in the traditional sense. It is about launching a new phase of collaboration. We see this as the beginning of a long-term partnership with WHO and collaborators and partners, one through which we continue to explore avenues for sustaining impact and scaling up integrated community-based models of care. The AUB Global Health Institute has long recognized that meeting the sexual reproductive health needs of refugees and vulnerable communities requires a multi-level approach. This is why our work at GHI in this area extends beyond this specific project. We've been investing in digital health solutions that extend care to hard-to-reach populations. We've created community-centered, evidence-based health education certificates tailored to lay populations, including refugees. We have supported frontline healthcare workers through capacity-building initiatives through the Academy Division of GHI that strengthens skills while promoting trust, cultural sensitivity, and resilience. And we've established communities of practice that ensure that our interventions have cascading impacts beyond the life of one project. Through all of these efforts, GHI is building more than knowledge. We are building systems, trust, and hope. And we are advocating for a regional health agenda that is inclusive, localized, and aligned with the realities on the ground. I would like to extend my deepest gratitude to all those who contributed to the SEEK project, from the WHO team who worked with us with technical excellence, to our partners at the Ministry of Public Health, particularly the Department of Primary Healthcare, whose ongoing commitment to inclusive health programming has made this work possible. Your collaboration is a powerful example of how national and international actors can come together to serve the common good. And above all, great thanks to AB's leadership for always trusting in GHI and the work we do and all the impactful projects that we are trying to do on the ground. I also want to recognize our project team. Your dedication, flexibility, and tireless work in challenging conditions, especially in the past 2024 war on Lebanon, which made SEEK not just a concept, but a lived experience for the communities we serve. And to all of you here today, thank you for joining us. This gathering is a unique opportunity to reflect, share stories, and lessons learned, and engage in meaningful dialogues and explore together how we can work all together collectively to support those in need. Thank you so much.
Thank you, Ms. Al-Arnaout. Next, we will proceed with a presentation on the Refugee and Migrant Health Program with Mr. Rawad Malaib, who is the program manager, and so that you can get to know more about the program flagship initiatives and the projects.
Good morning, everyone. It's a true pleasure to welcome you all today. Before I introduce the Refugee and Migrant Health Program at GHI, let's first set the context. We live in a region under conflict, where around 30% of the population are refugees, with ongoing economic, political, and system collapse, in addition to limited donor funding. This reality requires sustainable, innovative, evidence-based, flexible approaches that strengthen the health system while highlighting the need for collaboration and partnership. In response to these challenges, the Global Health Institute at AUB has established the Refugee and Migrant Health Program, RHP. The program addresses the effect of the crisis on the health of displaced and host communities in the Global South. RHP focuses on three main pillars: research, policy and advocacy, and community support. Under the research, we produce high-quality research aiming to reform the health system. As for policy and advocacy, our main goal is to inform policy and design evidence-based interventions. Moving to the community support, we empower frontline health workers through different capacity strengthening initiatives, including training, technical support, and leadership. Since the program establishment in 2017, we have managed to partner with several local, regional, and international organizations to implement some high-impact projects that aim to improve refugee health. We are proud of these partnerships and are continuously looking for new impactful collaboration to serve the purpose of this program. Let's focus more on some of the key initiatives and projects at GHI that were dedicated to improve refugee health. Among these, we cannot but mention Sijilli, the cloud-based mobile electronic health record, which feature partnership with Epic, the health software company. Sijilli was designed to secure and safely collect the stored health data of refugees to allow them and their health providers to access their data throughout the displacement journey and beyond. Next, SEEK, which is the focus of this event. SEEK project is a randomized community-based trial evaluating and integrated intervention to improve family planning, sexual and reproductive health, and well-being among refugee young women and girls. The Mobile University for Health, MUH, is a program dedicated to building the capacity of refugees and disadvantaged communities and enabling them to become community health workers through certificates focused on health and designed to be delivered to lay populations. Then we have Gain Me, which consists of a multi-level digital health and AI intervention that targeted disadvantaged Lebanese and refugees women in Lebanon, their spouses and their health providers, with the aim to enhance the uptake of maternal care services at the level of primary healthcare centers. This is a glimpse of what we do at GHI to improve the life and the health of refugees in Lebanon and beyond. Thank you for attending our event today. And for those who are interested in our portfolio, I would be happy to further discuss that in our networking launch. Thank you.
Thank you, Rawad. We now move to our first panel discussion titled Mapping Realities, Sexual and Reproductive Health Among Refugees Community. This session is moderated by Ms. Noor Al-Arnaout, Associate Director at the Global Health Institute at the American University of Beirut. Since the establishment of the Institute in 2017, Ms. Noor Al-Arnaout has overseen the design and implementation of multiple large-scale initiatives focused on health, capacity building, and institutional strengthening. She has also spearheaded the expansion of the operations of the Institute to 9 countries of the MENA region. Her work has primarily focused on underserved and vulnerable populations in fragile and resource-limited settings. Noor has published extensively about health interventions implemented in the MENA region. Her research emphasized on gender equity and equitable access to health services. She is a certified project management professional from the Project Management Institute and holds a master's degree in public health from the American University of Beirut with a specialization in health management and policy. Noor is also an inductee of the Gamma Delta chapter of the Delta Omega Honorary Society in Public Health. Ms. Noor Al-Arnaout, the floor is yours. I would also like to invite our esteemed panelists and experts to join us here, and those joining online to be ready. We have with us Dr. Michael Woodman, Senior Public Health Officer from UNHCR Lebanon, joining online. Ms. Wafa Kanaan, Senior Primary Healthcare Consultant from the Ministry of Public Health in Lebanon. Dr. Christine Qadi, Obstetricians Team Leader from Médecins Sans Frontières, Belgium. Dr. Rima Shaito, President of the Lebanese Order of Midwives in Lebanon.
Thank you so much for joining us today. I just want to make sure that Ms. Shaito is with us online. So we're going to start with the panelists who are with us here today. I'm going to proceed with the panel discussion and then introduce each panelist as we speak before we address to them the questions. So today's panel is basically about mapping realities, sexual and reproductive health needs among refugees and communities, what we know about the status of these needs, how we are addressing them, how different actors, including non-governmental organizations, governmental entities, UN agencies, and even orders and associations are addressing these needs. So we're going to start with Dr. Christine Al-Qadi. Dr. Christine, thank you for being with us today. Just for the sake of introduction, Dr. Christine Al-Qadi is an obstetrician, gynecologist with 9 years of experience in both the private and humanitarian sector. She currently serves as the obstetricians team leader with Médecins Sans Frontières, MSF, in Lebanon, where she leads clinical teams and provides technical support in delivering comprehensive sexual and reproductive health services to refugees and vulnerable communities. Her work spans antenatal and postnatal care, safe delivery, contraception, and care for survivors of sexual violence. In addition to clinical practice, Dr. Qadi is actively involved in training and capacity building initiatives, particularly with the midwifery-led model of care. Her commitment centers and highlights on improving access to rights-based quality sexual reproductive health services and promoting respectful maternity care and fragile health systems. Dr. Christine, thank you for being with us today. So to start, we'd like to understand from you from a clinical standpoint, what are the most prominent sexual and reproductive health gaps and needs among the refugee population in Lebanon. If you can just a bit elaborate on that, and how well are current services equipped to manage these needs, and where are the most critical gaps in diagnosis, treatment, and continuity of care?
So from the clinical point of view, working with Médecins Sans Frontières in Lebanon, particularly in underserved areas, urban, suburban areas, and also through my private work and public, in the public also health sector in various PHCCs in Lebanon, we observed many challenges and concerns related to sexual and reproductive health, specifically to vulnerable populations like refugees and the migrant workers, migrant populations too, disproportionately affecting, of course, these populations, and mainly, as mentioned in the introduction and by many, related to the displacement, to the socioeconomic hardship, to the insecurity, the legal issues, and the fragmentation and the fragility of the healthcare system. So from the most prominent concerns is the continuity of care, as mentioned. For example, most women seek help, especially when we talk about, let's say, antenatal care or other concerns late during second and third trimester. So we miss a lot of information that are needed for their proper follow-up. Maybe due to economic hardship, due to transportation issues, or even the lack of knowledge in the importance of seeking care early. In addition, for example, even for the ones who follow up early, and a lot of efforts are done to strengthen the primary healthcare centers through MOPH and other organizations to support the PHCCs. So women have the chances to go to PHCCs and follow their antenatal care early. They do. Some of them, they do. Then when it comes to secondary care, there is the lack of referral. So they follow up in a specific PHCC near their houses. And then when they want to deliver, they go to places where it's affordable for them. Not the same place, even sometimes very far from their homes, very far from where they followed up. If you look at an observation, for example, from the data of MOPH, VDO data for the deliveries, particularly, for example, in 2023, the highest delivery rate is in South, while the residency, they are mostly in Beirut and Mount Lebanon. So we can see that people are moving to deliver. Why South? It's the most affordable for them. Hospitals in South are less expensive than hospitals in Beirut and Mount Lebanon, and the coverage there for refugees is better, like related to UNHCR coverage and etc. So this poses risks. The hospitals, they don't know the patients. Sometimes they just come in labor, active labor. And this is particularly dangerous for high-risk pregnancies. High-risk pregnancies is a major gap, follow-up of high-risk pregnancies. They need a lot, multiple visits, ultrasounds, lab tests, medications, monitoring at home, glucose tests, for example, which is very expensive. So here we see a lot of gaps in the follow-up and the management of high-risk pregnancies. And when they go to a hospital where they are not aware of their cases, here comes the danger, high mortality, high morbidity. As also we saw that the highest mortality was in the South in 2023. Akrita cases, 4 Akrita cases were dead due to complications, of course, and bleeding. So this is a major concern and challenge. Second, the concern is the holistic care. Medical care is not enough. There are social needs, there are psychological needs. All these need to be addressed in the care of the patients. So there is like, these services are present, but fragmented here and there. You need to go follow up psychologists here. Social worker we do not have in this place. You need to follow up there, especially when it comes to sexual and gender-based violence. Sexual violence cases, they have multiple needs. The emergency medical care, psychological support, protection, legal, social, financial. So rarely you find all these in one place. Okay, so this is also a concern. And of course, with the vulnerable refugees, gender-based violence, sexual violence is high. You see that it is high in these populations. We also observe unmet contraceptive needs. Although also a lot of efforts are done by MOPH, by other organizations to provide, the fees are not that much, like they are not expensive, sometimes free, but still we see there's underutilization of these services. due to misinformation related to side effects, infertility, cancer, etc. Lack of the knowledge of the presence of these services. Sometimes partner and husband refuse. So here we need to involve males, we need to involve couples in the counseling. These are all major concerns we see. And when it comes to adolescents, to taboo issues, STIs, sexual violence, here we see the stigma, the fear becomes major barriers to seeking care.
Thank you, Dr. Christine. Before we move to the next panelist, I have two quick questions for you. The first is, how do you evaluate the level of compliance of Syrian refugee women with, following up on their tests, doing the right lab tests, imaging, and so on? And the second is, do you see that the decision of seeking healthcare is only the decision of the woman, or is it being influenced by her spouse, her mother, her community, and so on?
Yes, sure. Regarding compliance, it is low, but due to many factors. As we mentioned, like it's interconnected in many factors: displacement, financial reasons, socioeconomic, cultural. So as you mentioned, it's not her decision. She doesn't take all the decisions by herself. The husband, not even only the husband, the family, the whole family has to take decisions on her. You don't need to go early. Why? We delivered, we just like followed up, or we didn't even follow up and delivered, and there were no complications by her mother-in-law, I don't know, neighbors. So of course, it's not her decision, only decision. She doesn't take all the decisions by herself, influenced by all what she hears from the neighborhood, from the family, from the husband. But also the expenses. I mentioned high-risk pregnancies. They are very expensive. I said multiple ultrasounds, multiple labs. So here the compliance decreases. There are packages which are like they solved a very big problem, big issue. Those packages that are covered by organizations in the PHCCs are great. Once it is covered, they do it. Once you order, you ask for a lab test on an extra ultrasound, they cannot afford. They do not do it. Same for medications. If it's available in the PHCC for free, they take it. If it's not, they do not. They do not go and cannot buy it, either because they cannot due to its cost, or they consider it's not important. No, I don't need this medication. So also here comes the knowledge, the importance of education for the to properly seek help and care.
Thank you, Dr. Christine. And the importance is not only to educate the women and her surrounding, but also their healthcare providers, right? Because the more they let them feel the urgency of seeking these health services, the more they will feel, the urge to search for ways to actually seek these services. Thank you, Dr. Christine. Now we're going to move to hear from UNHCR through Dr. Michael Woodman. Dr. Mike Woodman is currently Senior Public Health Officer with UNHCR Lebanon and most recently at the Geneva headquarters. He is a physician and public health specialist. He has worked as a doctor and manager in several humanitarian crises across all continents worldwide, in countries ranging from Afghanistan, Somalia, Sudan, Sri Lanka, Democratic Republic of Congo, Myanmar, Chad, Kenya, Zimbabwe, Haiti, Ethiopia, Lebanon, and several other countries. Dr. Michael is joining us online. Thank you for joining us today, Dr. Mike.
Yeah, thanks very much. You can hear me? And unfortunately, I can't see the room, so just checking you can hear me.
Yes, we can hear you, and we will work with the IT team to make the view of the room available. So, Dr. Mike, my question to you is, what are the most pressing sexual and reproductive health needs and services gaps faced by refugee women and girls across different contexts, but not limited? So if you can expand beyond, the family planning, maternal health, menstrual health, prevention and treatment of STIs and access to safe care. And most importantly, because Dr. Christine shed light on lots of these health needs, so it would be good if you can give us an overview about how UNHCR and partners are addressing these health needs by either directly providing support or by partnering with different collaborators to make this possible.
Yeah, thanks very much for the question, and I'm sorry I can't be with you in the room, but I'm not in Beirut at the moment. So a number of previous speakers in the introduction have also spoken about the heightened vulnerabilities of refugees, and particularly their risk of GBV. So I think we won't dive into that too much, but what I'd like to emphasize is also health-seeking behavior, because we've talked a lot about access challenges, and that's come up frequently. The main access challenge is actually cost. I mean, there's a number of challenges that have been mentioned, legal, etc., but the financial barriers are by and large the biggest challenges. And linked to that is the socioeconomic status of the refugees, and that is basically 90% of refugees in Lebanon are living below the poverty line. So even very small costs, like an antenatal visit, as my colleague just described, these can be prohibitive and have a major impact. Also, what's been mentioned also is the mental health and psychosocial support angle, and particularly the need to focus on adolescent girls, which is a particularly vulnerable group that can be reached. And I'm hoping that through the SEEK project, you will be presenting positive results of interventions that can be scalable. I just want to mention across the region, the challenges are generally similar, but they're largely dependent on the number of refugees being hosted and how the national health system functions and the way donor support has been channeled vis-à-vis the Syrian crisis. And I think Lebanon is unique in the way that it does host the largest per capita concentration of refugees worldwide, and also the way the health system was structured with a largely privatized hospital system that has been a major challenge that I will come to. I just touch on a few issues that have already been mentioned, and the one is about family planning. The very relatively low uptake, with only 13% of 15 to 49-year-olds who are not single perceiving the need for family planning. However, of those who needed it, 95% could access it, according to the vulnerability assessment of Syrian refugees. My colleague has mentioned the issue about ANC and continuity of care. I think this is a critical issue. We know that only 54% of refugee women completed 4 antenatal visits. Again, costs was one of the major reasons. Moving on just to deliveries with the skilled attendant. Lebanon, 94% of refugees did deliver in a hospital, which is very encouraging, and it has always remained high, relatively high. About 3% of deliveries are with skilled attendants in midwifery clinics, but there's another approximately 3% who are delivering at home with unskilled attendants, which obviously increases massively the risks. And then, just linked to this, we cannot avoid the issue of neonatal intensive care, because there is a very high demand or need, and possibly a lot of this is related to poor antenatal care or incomplete. For example, last year we supported 3,000 newborns to be admitted to neonatal intensive care, but the costs are extremely high, and even though UNHCR was covering 60% of the cost, the patient share was largely prohibitive, and unfortunately we know of many patients who self-discharged because they simply could not pay. And then we've touched on gender-based violence, so I won't go into that more, except that it's a big challenge. There's a lot of stigma, underreporting, and services are largely fragmented. In terms of interventions, just very briefly, UNHCR, we are part of the coordination mechanism, so we work together with the ministry, with other UN agencies and NGOs, national and international, and try to address these challenges through a coordinated and multi-pronged approach. I mean, a large part of the approach has been supporting integrated health services in the primary healthcare centres, and I think this has largely been a great success, and under leadership of the ministry seeing this reform of the primary care system. There's also been a focus on community midwifery and outreach and communicating with communities. We try to mobilize outreach volunteers who are refugees, often with a health background. There's also midwife clinics in some of the remote areas. We've also worked together to provide significant support to hospitals, government hospitals, with a focus on MCH, donating incubators, respirators, and also trying to strengthen GBV services, referral pathways, including access to PSS, clinical management of rape, and forensic doctors. And then just to mention, we also directly support access for refugees to hospital deliveries by paying 50% of the fees. But as my colleague mentioned, refugees may move around looking for a cheaper option where their patient co-share is less. Thank you.
Thank you, Dr. Woodman. Very interesting, and we'll follow up on this discussion and the role that the UNHCR plays. So now we're going to move to Dr. Rima Shaito. Dr. Shaito is joining us online. So just as introduction for Dr. Shaito, Dr. Rima Shaito is the president of the Lebanese Order of Midwives and lecturer at the Lebanese University, Faculty of Public Health, Midwifery Department in Beirut, holding a PhD in Public Health from the University of Montreal with additional master's degree in Health Sciences, Education, Epidemiology, and Public Health. She has extensive experience in sexual and reproductive health, including serving as project director for a UNICEF LOM partnership and coordinator for various initiatives with UNFPA, Oxfam, MARSA, and other international and UN agencies. She has expertise in capacity building, planning, monitoring, and evaluation of reproductive health programs. She is a member of national committees on midwifery, competency assessment, hospital accreditation, neonatology, and infant and young child feeding. She represents the Lebanese Order of Midwives at the International Confederation of Midwives, and she has research interests including reproductive health systems, and human resources for health. Thank you for joining us, Dr. Shaito, today. So, Dr. Shaito, our question to you is, we all know the essential role of midwives, especially in fragile contexts and underserved areas in Lebanon and beyond. So can you kindly elaborate on how well prepared and equipped are midwives, particularly those working in rural and underserved areas, to address the sexual and reproductive health needs that Dr. Christine and Dr. Woodman elaborated on? And what more is needed in terms of training or capacity building to support the midwives do their jobs more efficiently and effectively?
Thank you, Noor, and thank you for the invitation. Sorry I cannot be able to be with you due to change on my flight and the situation in the area. Let's start by the challenge that through our experience as midwife, the refugee or the migrant woman faced. I can start by the many challenges are noted as social stigma and fear of discrimination. Many women are worried about judgment or negative repercussion when seeking sexual and reproductive health services, which can delay or prevent some care. And I add some language and cultural barriers, maybe difference in language and cultural norms, especially around some subjects like contraceptive, GBV, or adolescent sexuality, limit the open communication with the migrant. And I add also the economic and logistical obstacles, the transport cost, consultation fees, and opportunity cost of missing work during when seeking care. And maybe the last one, it's the legal and documentation issues, lack of valid residency paper or health coverage insurance. This issue can alterate or delay the seeking of the seeking of care, especially in public facilities, through documentation or paper. They are asking about the papers, and information gaps are about the services available. Refugees or some migrant especially are unaware of the health rights. About the preparedness of midwives, you ask about how are prepared. In some area, midwives are especially in crisis, during a crisis, they are in the front line and among the first people who respond during a crisis. And in the last year, with the collaboration of all UN agency and the Ministry of Public Health, the midwives who are working in PHC are prepared and they received many training regarding the communication maybe and the communication and the approach to be used by midwife. But still we have some gap and the gap maybe in the midwife who are working in private clinics. They need more preparation on culturally responsive communication, need more skills how to work with diverse linguistic and cultural groups, and how to deal with migrant or women, refugees and all women on GBV approach and GBV care. They also need more mental health integration, to integrate the mental health approach with when delivering care. And we have the problem of lack of resources in private clinics. I think it's more training, capacity building are required to equip midwives who are working in clinical, especially in remote area, about the approach and the skills to deal with migrant and refugees.
Thank you so much, Dr. Shaito. In fact, I would like to highlight one of our experiences at GHI in a different project, also focused around sexual reproductive health services. The project involved targeting both OBGYN doctors and specialists and midwives, and this was done in partnership with the Ministry of Public Health and UNRWA. And we noticed that the midwives had much more passion and this whole willingness to learn and deliver better services to the disadvantaged populations compared to OBGYN specialists who assumed that they are much busier, they had a bigger load and so on. And we noticed also from our interaction with the refugee women that they felt more comfortable talking to the midwives compared to the OBGYN specialists. So this is also to follow up on your discussion. Our last panel, yes.
No, I want to add something. It's not about, it's midwives and gynecologue, they are working together. It's a complementarity. And the midwife, she's trained and in her formation يعني university training and philosophy of the midwifery, it's to be near the woman and to accompany the woman. The gynecolog يعني عندهم they have their approach, their medical paradigm, maybe it's about the complementarity, and midwife يعني its work, it's to be patient with the patient, and maybe the gynecolog يعني عندهم they انه are يمكن disponible for available for more specialized care.
Thank you, Dr. Rima. Definitely a complementary role, and we should not also forget the role of the nurses who are always involved in delivering such care. So our last panelist on this panel is Ms. Wafa Kanaan. Ms. Wafa is a senior PhD consultant at the Primary Healthcare Department at the Lebanese Ministry of Public Health and a certified national accreditation surveyor. Wafa holds a degree in healthcare management and quality and has been working at the Primary Healthcare Department since 1995. In 1995, she joined the Ministry of Public Health as a Family Planning Central Coordinator and maintained this position for 3 years. She was later assigned as a Reproductive Health Senior Coordinator, where she held this position for 6 years before being assigned as a Senior Primary Healthcare Coordinator. With her extensive experience in primary healthcare, reproductive health, and immunization programs, Wafa was assigned as a Chief Central Coordinator at the Primary Healthcare Department at the Ministry in 2015, and then a Senior PhD Consultant in 2021. She has many contributions in working at the governmental level to guide and supervise the delivery of high-quality primary healthcare services to the Lebanese citizens and refugees in Lebanon. In 2017, she was assigned as a certified national accreditation surveyor by Accreditation Canada. And personally, شهادتي مجروحة بمس وفا لأنه she worked with us on one of our biggest projects كمان with the midwives and doctors and primary healthcare centers, and we're always pleased to repeat this collaboration with the ministry. So, Ms. Wafa, شوي هيك at the policy level, at the health systems level, my question to you is, how effectively is the national health system responding to refugee women's sexual reproductive health needs? What are the main policies, financing, and operational barriers to strengthening this response? And what's the role of the primary healthcare system in Lebanon to respond to them?
The national health system is led by the Ministry of Public Health and is supported by 300 primary healthcare centers and PSUs, primary healthcare satellite units, under many agencies, UN agencies and INGOs, the PSUs. These all deliver or provide sexual and reproductive health to all population residing in Lebanon and also for refugees, women. These centers provide SRH services, including family planning, antenatal and postnatal care, STI screening and treatment, and also early detection of reproductive cancers at minimal fees at the primary healthcare centers. Also, several of these primary healthcare centers are supported by INGOs and are providing or offering the Lebanon primary healthcare subsidization protocol, which contains packages of services. And these centers that provide the SRH services through these packages provide the wellness package, which contains the SRH services, including family planning and other services for the population, and also the antenatal package and postnatal package. So these are offered at very minimal fees at these supported centers. Also, these centers, if we want to speak about the gaps, we have so many gaps at the national level. We have policy gaps, financing gaps, and operational gaps mainly. At the policy level, we don't have a national policy that includes SRH services for the refugees. And also, under this barrier, we have fragmentation in services. Like we don't have all the services that are provided for mainly the refugees are under the government. Yani so many NGOs, UN agencies, and other entities, they provide services like fragmented or parallel services to the refugees, mainly on SRH. So this is a very important barrier. And also, we have under the financing barrier, we are depending on the donor finance or donor support. And now, as you know, all the donors, or mainly the EU, are shifting their tasks through other countries and other, not in Lebanon and for the Syrian, mainly Syrian refugees. Also, at the financing barrier, we don't have any budget for the primary health care centers at the Ministry of Public Health. And this is, mainly is a very gap and barrier, because we as government, we cannot support these centers. So at the ministry or at the primary healthcare centers, we have several centers, like mainly half of these centers are supported by NGOs, and the other are not supported by anybody. And this is a main gap in providing services, mainly SRH services. Also, for the operational barriers, we have overstretched primary healthcare centers and also PSUs because of the volume of the population that they are serving, and shortage in human resources and in all resources at the primary healthcare centers. And we have a weak referral mechanism. So this is a very a gap and a main barrier in providing SRH to refugee women. The role of the PHCs, as you know, that PHC centers are the main gate for providing the basic and essential services for the population, and mainly the SRH services. So for these primary healthcare centers, the role is to enhance accessible and affordable and standardized services for the population through these primary healthcare centers, to strengthen the referral system, and also to have these packages more utilized in the primary healthcare centers, mainly that now we are paving the way through co-financed governmental finance that will help and support the other centers that are not supported by anyone. So this is a main issue.
Thank you, Ms. Wafa. Just to complement the discussion that's happening, I'd like to address Dr. Woodman with a question. So we've all heard about the downsizing that is going on with UNHCR and other UN agencies as well. So with this downsizing, how are you planning as UNHCR to maintain the level of support or the type of support that you are providing to refugees in Lebanon when it comes to sexual reproductive health?
Thanks. That's a tough question. So I think you're all aware of the global funding or financing crisis that is facing not only UN agencies, but also a lot of NGOs. And this is as a consequence of the withdrawal of the United States government from their normal funding commitments. UNHCR was funded approximately 40% of our funds were from voluntary contributions from the US. So the impact has been dramatic, and it is it's worldwide, and it's of course also going to have a dramatic impact in Lebanon. And what does this mean in practice? That we simply will not have the funding to continue supporting access to healthcare to the level we have been. And what I just want to appreciate or recognize is the work that has happened to date, and particularly, what Wafa has been talking about, the primary healthcare network. And yes, of course, there are gaps, and we've mentioned them, but I think the successes are also enormous. What has been achieved with all these challenges, people have still managed to have access to services, and relatively affordable. So despite all the cost challenges, at least at primary care, there is a basis. And UNHCR has not been, or has been progressively withdrawing support from primary care over the years, because we've largely had to focus our budget on hospital care, which has unfortunately been consuming all of our budget. And our health budgets in Lebanon have been the highest in the world globally, and continue to be so. It is the largest budget. But regrettably, this financing will be coming to an end, and the question is about sustainability, and this has always been our concern since the onset of the refugee crisis, when we were relatively well funded. As colleagues have said, there was a big donor support outpouring. We had a lot of funds, and we could provide extensive support. And this has been dwindling over years, and it's been a trend. But now we are standing on the edge of a cliff, and it drops dramatically. And we were always thinking about sustainability. How could we find sustainable solutions? Exploring things like health insurance, social health protection. But the systems are not very highly developed, even for vulnerable Lebanese. So our principle is always to work on equitable solutions for refugees, but the entry points were limited. We also reflected on the possibility of pooled funds, where donors contribute to a pool fund that can then support the ministry, or requests for bilateral financing, development financing. And I think this is really critical, is that we're in a very protracted situation now. We're talking 14 years. UNHCR is a humanitarian agency, is not a development agency, and I think we are struggling to bridge this humanitarian development peace nexus. We all know what it is, we can describe it, but it's a bit like a unicorn. Everyone can describe it, but no one really has seen it in action. And I think there are a lot of challenges, because Lebanon is being middle income, is not eligible for grants from the international financing mechanisms. They have to take loans, and this is always a challenge, expecting a country to take loans that they have to pay back, even if the interest is low, investing in a refugee population. So I think going forward, we're in a very difficult position. We are asking donors, the international donor community, to step up to support Lebanon. We're asking partners to do so, but many of them have the same issues. But I think what we need to do is maintain a focus on SRH, because of all the needs we've discussed, and to make sure that people have access to comprehensive reproductive health services and safe delivery, because what we don't want to see is a rise in maternal mortality and neonatal mortality. But I think we're also at a crossroads. Just on a positive note, the developments in Syria, the intention to return is increasing, and we are expecting this year probably a dramatic return to Syria. Before the end of the year, we're expecting the intention. Refugees are telling us they want to return. On the converse, Syria needs support, because their health system is also in need of massive reconstruction. But I think we're at a crossroads, and with a lot less refugees in Lebanon, maybe the resilience of the health system and the remaining partners can step in to top up additional support. I'll leave it there.
Thank you, Dr. Woodman. In fact, the situation, it is challenging for all of us as key stakeholders in this field, because we always work assuming that there is a continuity and a closed cycle. So we, as academia, do the interventions, the NGOs and the primary healthcare centers work at the level of providing this primary healthcare, and then agencies like UNHCR work on the hospitalization and other kinds of support. And any missing piece from this puzzle will lead to a challenging situation to all of us. But as you mentioned, there's hope as we see more and more refugees going back to Syria, and this underlines our role now in trying to contribute to rebuilding this whole healthcare system in Syria and other countries that are witnessing different protracted crises. So thank you, Dr. Woodman. Dr. Shaito, how do you think that different initiatives can support midwives in doing their job in a better way in such resource-limited context? So what types of initiatives as order you support, you are engaged in to build the capacity of the midwives practicing in these settings?
As Lebanese Order of Midwife, we are aware about the situation, because all the initiative was supported, as Wafa said, by UN agencies and INGO. But we are thinking about sustainability. For example, the training issue and capacity building to deal not only with refugee, but with the vulnerable women in Lebanon also, and migrant and other population, by building the capacity of the order. As LOM, we are young. The Lebanese order was established since 2014. So we are thinking about having a simulation center and training center in the order, okay, to continue to build the capacity building of the midwife about this issue, the concept of the women's rights, and all the not a new concept, but the gaps. So in establishing this training center, and we can sustain this capacity building, and we are thinking about with the midwifery schools to integrate in the curricula all the gaps that we mentioned above. So and the third issue, it's about the regulation and the reglementation of the midwifery in Lebanon. So we can amend some issue in the law to integrate some criteria of quality in the curriculum and the training and the performance of the quality of care by controlling the practice of the midwife. So the problem, no, it's well diagnosed, but we think that as a formal body responsible of the training of the midwives and the practice of the midwives, we can work on the capacity building and the control of the practice, especially in clinical midwives, to guarantee a quality of care.
Thank you, Dr. Shaito, and it's great to know that you are planning to establish this training center at the order, and good luck for that. So my last question is to both Ms. Wafa and Dr. Christine. How important do you perceive the whole notion of trying to establish communities of practices by equipping members from local communities such as refugee women, disadvantaged women, to be able themselves to deliver more information related to sexual and reproductive health to members of the community, and to enable them to themselves act as active members of the community and referral points that can help both the primary healthcare centers and the NGOs working in this field to refer the patients when needed, to provide them with the needed health education. And do you perceive that having a member from the community as community health worker can increase this, whole trust among the women from the communities and enable them to seek services more at the level of primary healthcare centers?
Yes, this is very, very important. And we have like an experience now. We have like a Salami initiative with UNICEF. This Asalami initiative is based on community services. Yani the team of the PHC center that is within Asalami should have a midwife and 2 community health workers. And these community health workers should be from the community. Yani they know well the community. They go and to the houses. They provide awareness and education information about the primary health care center that is the closest to them. What are the services provided in this center? How can they access this center? If it is affordable, and all the information about, because the main gap, and I didn't mention it because all the others mentioned it, that lack of information of the beneficiaries, accessing if they are refugees or not refugees. Here, the lack of information about the services that the primary health care center provides. So even if they access the primary health care center, mainly they don't know about the SRH services that are provided in this center. So we have to go out to the community, and this initiative, it was a very good experience to us, that motivating the community and informing them about all the services of the primary health care center, and about all the services, mainly on SRH and pregnancy and all of that, because the midwife come in, she conduct field visits to the houses, and also if there is a pregnant woman at the one of the houses, she can manage her pregnancy and refer her to the closest primary health care center. And also, as accreditation program, we have a standard in the accreditation that should, any primary health care center should have a community committee. And this community committee helps and supports the center in providing or conducting needs assessment for the community and the services they are in need, and mainly also for SRH services. So we have this experience, and this is very important. And as a solution, as primary health care centers and as ministry, we are now enhancing community engagement in all the health needs and health services in order to have all the population utilize all the services at the primary health care center, to seek all the services they are in need. So this is very important for us. And we have so many experiences, like with all UN agencies, if UNFPA, you as GHI, as you mentioned, we have 2 projects that were in the community and they were very successful. So it is, community engagement is very important to all population, for refugee and other population, in order to raise awareness and educate the population and give them the accurate and correct information.
Thank you. For sure, education is essential. We have many methods for education, tech-based education like social media, which will for sure not reach the ones with internet access, will not reach the ones who are able to check these websites. We have the community outreach through the health promoters, through the community midwives, which will go to the community and deliver the messages and what we want. But the peer education that you are asking about is very important. Mainly, it will really help with the referrals. They know the community, they know the most vulnerable, they know the language. For migrants, for example, it's very essential to choose people from their community who can understand their languages. With the NGO that I'm working with, we have this experience. We have community health educators that are from the community itself that knows all the languages of the migrants, for example. So they are well trained. This peer education, we train them. They know the services, and then when they are in there, they can see the needs, they can detect the needs, the problem, the issues, and they can refer to the primary healthcare centers, to other services, CMR, let's say, facilities, services here and there. So very important to reach the most vulnerable, the most in need is peer education, the ones who are living in the same place, having the same needs, and having the same challenges.
Thank you, Dr. Christine. And now we're going to open the floor for questions from the audience.
سامر حماية لجميع المهمشين. I work with a local organization advocating for the rights of marginalized communities that also supports refugee communities. During and after the war, we saw firsthand how emergency responses, mainly when it comes to SRH, they deprioritized SRH services, particularly for gender non-conforming refugees. So, for example, at schools hosting displaced refugees and mainly gender non-conforming refugees, my question is, how, from an advocacy perspective, advocacy related to SRH, do we integrate and how do we advocate for the intersectionality when it comes to this topic? And how do we integrate this perspective into a national health plan and strategy? I'm talking about intersectionality, تقاطعية.
If at the national level, maybe I'm not the one to answer how to integrate at the national level. Maybe it needs more change in regulations, more inclusion of these communities, marginalized communities in the laws and the rights. From the NGO perspective, we talk about NGOs, they are always included. But, as I mentioned, each NGO serves specific, let's say, a community or specific, it's not like overall all over Lebanon. And especially when we talk about emergencies, then, as you mentioned, at the national level, they are deprioritized because there are more, let's say, wounded patients, traumas, and etc. So they always tend to support these. But as NGOs, they are always considered. They are always part of the plan. They are always part of the emergency response. But at the national level, maybe Mrs. Wafa can respond.
As she mentioned, as Dr. Christine mentioned, but at the national level, we don't have these services integrated in the PHC centers. We support NGOs that provide these services, but also she mentioned that we have to have regulations, policies, and everything before we provide these services for these yani, groups. So we support NGOs supporting these groups, but we don't have, because it needs so many, yani first we have the regulations, the policies, the capacity building for the healthcare providers. There are cultural and religious issues, so many issues yani, on the national level. So we support indirectly the NGOs that is supporting these groups, but at the primary healthcare centers, we don't have this.
Hello, Miriam Abu Abdallah from IMC. So, Mrs. Noor, you asked Dr. Woodman about the sustainability and the next step following maybe the downsizing or the decreasing of the fund. I would like to ask also Dr. Woodman and Madam Wafa technically about the steps and the next phase. So we all know that maybe the funds will decrease, but technically on the ground, what can be the issues, the challenges, and maybe the gaps, especially for the SRH in the secondary care. So the morbidity, the mortality will increase. These people will not found any support for deliveries. The maternal maybe death will increase. So do we have any plan or any mitigation plan before maybe entering to this phase?
Yes, sure, we have a mitigation plan. Now we are planning to expand the LPSP protocol to all other non-supported centers in order to let them start providing services through these packages, and we are paving the way for governmental-led finance as the INGO is supporting. And also, we have also a plan to link the primary healthcare center and the governorate to a governmental hospital, and will start in referring to higher level the deliveries. Yani the pregnant woman who will be who will be accessing the primary healthcare center for antenatal visits, she will be referred to the closest or the governmental hospital to have the deliveries for free. So we'll start with the deliveries and we'll expand later. But now this is our mitigation plan. Thank you.
Dr. Woodman, would you like to answer this question as well?
Yeah, I'll just come in with a few reflections. So yeah, as what I first said, I think it's excellent that there's national initiatives to mitigate. We've had discussions with several partners, NGO partners who are still active in their areas, who may be able to step up and provide some support specifically for deliveries. Recognizing that the average cost is not that high, actually. It's, according to our data, about $170 when we look at...
sorry, Dr. Rodman, I have to clear something, that this linkage between the primary healthcare center and the hospital is only for the Lebanese in the later stage, not for all population residing in Lebanon.
Okay, I missed
it will be for the uncovered,
yes.
يعني اللي حسب الوزارة that MOPH coverage, and we will also cover the 20% that the beneficiary or the share of the beneficiaries. So, yeah. Only for the population, Lebanese population.
Right. So this is where we talk about equity, where we need to find some financing that steps in and says, okay, for the vulnerable refugees that remain in Lebanon, as we've said, we're hoping that we are expecting to see a massive return, that there would be an equitable package. But the question is who will finance this? And this is the intense advocacy we have to have. I know different partners in their areas will step up, and we've heard already they are planning to do so, but it may be a bit piecemeal and fragmented. You know, for example, maybe MSF who's working somewhere, those who still have funds. we will not be abandoning refugees because I said we're not a health agency but protection. So we continue to target cash assistance for the most vulnerable, and this is an agreement with MOSA. So vulnerable refugees receive a monthly cash allowance. This is what we call MCAP, or multi-purpose cash assistance, and it's to cover essentially basic needs. So it can be, people typically use it for food, for shelter, but we know a lot of them also use it for health costs. So we still will be looking at how we can protect the most vulnerable refugees with the resources we have, but it cannot be through the existing arrangement we have. You know the arrangement currently through a TPA who manages. So we will still be looking at providing cash assistance to the most vulnerable, and even exploring cases where some top-up may be possible, because I think deliveries is one thing we may be able to find solutions with partners. What I'm particularly worried about is the neonatal intensive care, because people will simply not be admitted. You can see what will happen. There will be a need for admission, a deposit of $1,000 or end bill of $15,000. People will just self-discharge, which we see already today. So I think this is going to be a critical area, and we will be working hard with donors and partners to try and find mechanisms and support for this. Over.
Yes, sure. I think MSF and all other NGOs are monitoring closely the situation. And I think that we think that the burden will be high, and I don't know if it will be really handled by, of course it will not be handled by one organization. It needs a lot of efforts from all other organizations to absorb this. And as mentioned, mainly the NICU cost is high. We have an experience, we had a birth center and antenatal care not supported by MSF, like covered completely by MSF, and the NICU was the highest, and it was a really high budget. So we need to monitor closely, and I think all NGOs, MSF is doing this, all NGOs should be doing this, but the burden is high, and let's see how they can handle it.
Okay. Thank you for GHI. I'm Mirna Doumet, AUB School of Nursing, for raising this important topic, and thank you for the panelists for giving us such important information. I have quick points. Noor, you highlighted that in one of the studies, women were more happy with the midwives, and I can extrapolate this to many studies done on nurses, where patients were much happier and they received a good quality of care when we had nurse-led clinic, and the cost was less because of the time and the care that they are given, that physicians, due to the time constraints, cannot give it. Of course, just to respond to one of the panelists, when we want to give care to women, we need to be holistic. It's not only the physical, especially when we talk about pregnancy. We have the psychological care, we have the environmental care. And the most important thing that we teach our students at all levels in nursing, that when you want to give a teaching, you have to be astute and look at the gatekeeper in the family and who is the decision maker. Knowing the Syrian community and having volunteered in an primary healthcare centers and worked with them, I know that many of the times the mother-in-law is the decision maker. So if we want our teaching to be implemented, the teaching has to incorporate the person who is the decision maker. Of course, my question is to Dr. Christine and to all others. Knowing that we have a return plan and for the Syrian refugees, and knowing that all money will go to Syria to rebuild Syria, the question is, how do our Lebanese women coming from low, middle socioeconomic level do compare to what the Syrian do compared to Syrian women who are seeking care at the primary healthcare centers? Also, our Lebanese women are not covered, no insurance. The Ministry of Health stopped the coverage, so they are living the same crisis. And I hope that the money also will cover those women who are not able to go and seek antenatal, prenatal care. Thank you. And how do they compare, Dr. Christine?
Okay, yes. The services provided by MSF is for all. So there's no discrimination related to, let's say, it's only for refugees and not for Lebanese. So services are free of charge and for all. Everyone who seeks the help of MSF will receive it. Of course, I should highlight that in the previous years, and we saw the change after the economic crisis, the majority were refugees, Syrian refugees. With the economic crisis, we started observing more Lebanese coming to our clinics and seeking care, which they are always welcomed. So yes, this also shows that due to all what's happening, the economic crisis, that Lebanese are facing more and more challenges in seeking care, on accessing care, but it's always open for all. There was never discrimination. All the services are equally for all. If they seek, once they come, they are welcomed. And we also had many steps to encourage Lebanese to come also, not only like we're just open. We went to PHCCs when we had the birth center for free, deliveries for free, encouraging Lebanese to come and deliver for free in the birth center of MSF. So we had steps also to encourage Lebanese to come and receive these services from MSF.
Also, as I mentioned, Doctor, that we have this mitigation plan for the Lebanese, and we are now preparing. The government will buy the services from the primary health care centers that are not supported, as they buy the services from the government, from all the hospitals, and will cover the delivery, as I mentioned, for the Lebanese. At the primary health care centers, there is no discrimination. Any beneficiary can seek or access the primary health care center and seek any service. If it is supported, it's the same for the Lebanese and non-Lebanese, except for Riaya project, which is the World Bank project that is for full Lebanese and not all Lebanese. It's only for the families that are extracted from Aman program at the Moza. So these are for the Lebanese. And at the primary health care center, we have no discrimination between Lebanese, non-Lebanese, migrant, even the legal status. Before the system cannot, we cannot enter the data if the beneficiary doesn't have any official papers or documents. But now it is open for any refugee, Lebanese, even if they don't have official documents or any legal documents, they can access the primary health care center and seek all the services at the primary.
Hello, yes. My name is Farouk. I'm representing ASC Canada. One of the main questions I have is kind of pertaining to what was stated and similar to the former question, which is about the learning, the knowledge, being able to give the awareness of the resources and what is available and how we can get by these barriers of stigma, perhaps like cultural barriers, also gender-based barriers where a lot of the houses are led by the patriarchal head, and as a result, there's a lot of lack in being able to learn more and access these resources. So it was suggested that there needs to be more education or more training for the midwives in order to present this. There's always a fear when it comes to this of having our frontline service providers, having the people that are on the front lines being burnt out by all the work, being burnt out by all the extra demands. So how do we overcome that, or more so, how can we get to a level of learning and being able to have that knowledge mobilization without burning out our frontline workers?
Do you have any specific
No,
analyst
no,
in mind?
I'd love
It's
just
a-
like general sense on this.
So I can reflect on our experience at one of our projects at the Global Health Institute. So we were well aware of the level of burnout that most of the healthcare providers, especially the frontline healthcare providers, are facing at the primary healthcare level. And what we designed is we designed a monetary incentive system coupled by sort of a game that aimed to improve their knowledge in sexual and reproductive health. So there was a game that was, it was a mobile app that was tailored to health professionals, particularly OBGYN specialists and midwives. And they were supposed to use this game or this application to learn about different topics related to sexual, reproductive, and maternal health. And the more they engaged in answering questions and using these applications and learn from it, and the more questions they answered correctly, the more there was probability for them to win a monetary prize every month. So this was our way to motivate different healthcare providers to stay engaged with us in an intervention that aimed to actually build their capacity and keep them up to date on the best practices when it comes to sexual, reproductive, and maternal health. This is one mere example of how we can, motivate health professionals. But I'm not sure if Dr. Wafa has anything to add.
No, capacity building, maybe like on the social media, maybe مش on social media, by videos. We have lots of videos, tutorial videos for different programs at primary healthcare centers, primary healthcare department. Also, the capacity building that we always provide for the healthcare workers at the primary healthcare centers, for all the midwives, nurses, physicians, for all the directors. But we cannot pay incentives like if we to motivate them to learn more. And maybe we it's the most important thing that they get a certificate from the Ministry of Public Health. And this is maybe sometimes we motivate them in getting this certificate, but this is what we have.
I just want to add something important and very useful to increase education. Education should be used and part of the routine care. All healthcare providers should have into their account, like during the consultation, during providing the care, there should be education part of it. So if we make use of, for example, the antenatal care visit to educate about SGBV, sexual violence, gender-based, about STIs, about breastfeeding, family planning, contraception. So this is a routine care, patients are coming in, so we take advantage of it to educate about different topics. Vaccination. A lot of people come with their children to vaccinate. There is waiting time, waiting area where education also with health promoters can be beneficial, and even with the consultation itself with the healthcare professional. So if we include education during routine care to be part of our routine medical care, this will increase the level of knowledge and level of education to all the population that we serve.
Good morning. Hi, this is Miriam Naufal from IMC. We're talking today about sustainability, but also in light of all the decreased funding and all of that, I wanted to ask you, Dr. Wafa, about the 300 network of 300 PHCs, basically, that are currently potentially moving towards localization, which is what we should be mostly focusing on. So I wanted to ask first if this is an effort that is currently being coordinated. How is the capacity building going? Like, what are the steps that are being taken? And second, how can international organizations or potentially actors that are still supporting until they phase out potentially, how can they still support in the coming phase? Thank you.
We hope that they will continue supporting. So as barriers, I mentioned that we have like fragmentation in providing services, mainly in SRH. So I think, for your question, I think that the Ministry of Public Health, mainly the Primary Healthcare Department, should enhance the intersectorial collaboration and coordination for providing health services, mainly basic health services, and especially this SRH services. So as we did after the Beirut blast, we have let all the international NGOs, the UN agencies, all the partners that are supporting the primary health care centers, we have this national platform, and from there we went for providing providing the packages, subsidized packages, until we had this LPSP now. And we, in the future, we are enhancing this and expanding the centers that will be implementing the LPSP packages in order to have in all primary healthcare centers standardized, affordable and accessible services. I don't know if I answered your question.
Thank you so much, everyone, for continuing to be with us in this panel. The last comment from Dr. Shaito. We will continue this discussion over the networking section, but we will have to move forward. So Dr. Shaito, the last comment is yours.
Thank you. I need to add, I want to add something about capacity building. Capacity building, it's one of the mandate of the orders, even of the Lebanese Order of Midwife or Lebanese Order of Nurses. And CME, or Continuous Medical Education Development, Professional Development, is one of the mandate of this order. And there is some hours, it's mandatory to do some training, about 30 hours per 2 years, and some subjects are fixed to be the subject of the capacity building. So for the sustainability, the order are the reference to maintain the capacity building of their members as LOM or nurses.
Thank you, Dr. Rima. And with that, we come to the conclusion of this panel. Thank you for our panelists, and we move forward with the program.
Since its establishment, the Global Health Institute at the American University of Beirut has invested quite a bit in addressing the health needs of refugees in MENA, particularly those in Lebanon. In fact, many of the Institute's projects focused on that purpose, and the SEEK trial is one of these flagship initiatives. We started working on the SEEK trial back in 2023 in partnership with WHO and supported by ELRA.
I'm proud to have collaborated with the AUB Global Health Institute on the SEEK program, which aimed to empower Syrian adolescent girls and young women with access to family planning and mental health support.
The initiative aimed at improving the access of Syrian adolescent girls and young women refugees in Lebanon to sexual and reproductive health services, while also strengthening their mental well-being. The program included training Syrian paraprofessionals for a period of 20 days with support from psychologists, midwives, and local women from the community to create a safe and supportive learning environment and empower them to deliver the needed services and education to the targeted refugees.
Our partnership with AUB GHI didn't just bring scientific rigor and trust, it proved that adaptability and collaboration are essential to success, even in conflict settings.
In coordination with the Department of Primary Health Care at the Ministry of Public Health in Lebanon, we were able to work together with the trained paraprofessionals to provide free OBGYN consultations and hygiene kits to more than 480 adolescent girls and young women through 19 outreach health days that were held.
The beneficiaries also took part in 8 interactive sessions that covered the full WHO package, blending psychoeducation with sexual and reproductive health education to empower them to take control of their health and their futures.
بدي أتشكر معهد الصحة العالمية بالجامعة الأمريكية ببيروت اللي أعطاني فرصة كقابلة قانونية إني أشارك بمشروع سيك. مشروع سيك هو عبارة عن 8 جلسات جماعية. المواضيع اللي تطرقنا لها هي العلاقات الصحية، الحدود الشخصية، صحة الدورة الشهرية، وسائل منع الحمل، وكيفية الوقاية من الأمراض المنقولة جنسياً.
كانت مدة التدريب 20 يوم، تعلمنا فيها كيف نقدم الحزمة المعتمدة من منظمة الصحة العالمية، وكمان تعلمنا فيها كيف نقود جلسات عن التواصل والموافقة والأمراض المتناقلة جنسياً والحيض وغيرها من المواضيع. خلال تقديم الجلسات اشتغلنا مع أخصائيين نفسيين وقابلات قانونيات ونساء سوريات من المجتمع المحلي، وخلقنا بيئة آمنة وداعمة لكل مشاركة.
عطاهم الفرصة بأنه هن يعبروا بطريقة واضحة، أكيد من خلال مواضيعنا بالجلسات اللي عملناها، مثل كيف نبني الثقة بالنفس، كيف نحط طرق لحل المشاكل، أكيد يحطوا حلول وأفكار ليقدروا يوصلوا لحل مشكلتهم.
اللي تعلمته من مشروع سيك اني كيف افتح حوارات صريحة مع زوجي. قبل ما كنت اعرف كيف احكي معه، بفتح معه حديث عن تنظيم الأسرة، اما هلا صرنا نتفق على اتخاذ القرارات لكلينا، مش الي وإله.
قبل ما أشارك بمشروع سيك ما كنت أعرف كثير شغلات عن جسمي وعن حقوقي وعن هالشغلات. بعد ما حضرت المشروع وهيك بطلت أخجل من هيك مواضيع، وصار عندي ثقة أكتر ومعرفة أكتر.
حس صار عندي ثقة أكتر وصار في وعي ومعرفة أكتر من قبل.
To complement what we have watched in this video, we'll now move to a short presentation on the SEEK project, focusing on its implementation and evaluation. This session will be delivered by Mr. Hadi Naal, research consultant at the Global Health Institute at the American University of Beirut.
Good morning, everyone. So my name is Hadi, and I'm a research consultant at GHI. So today I'm going to be presenting the evaluation findings from the Self-Efficacy and Knowledge Trial, or SEEK, which is, as we've discussed, a low-intensity, low-resource, community-based intervention tailored to fragile settings. But before I start, I would like to acknowledge the amazing work that my colleagues at RHP did on this project, especially Asma, who's standing over there. Who was really the engine driving all the coordination and all the fieldwork associated with the project, despite all the challenges that presented along the way, as we will discuss in a bit. So thank you. Thank you. In response to the critical SRH-related service gaps, which, among the refugee communities which have been discussed extensively today, WHO developed SEEK to improve family planning, SRH, and well-being among refugee women and girls aged 15 to 24. And what's special about SEEK is that its focus on being community-led. So it's designed to be led by paraprofessionals, or we can also call them community health workers, who are themselves refugees. And this is important, as we will see later on, to ensure a culturally sensitive approach to the work that we do with these communities. And in addition to that, what's also special about SEEK is that it not only focuses on improving knowledge, but also on addressing interrelated factors in an integrated manner, as you can see here. So other than SRH and family planning topics, it also covers emotional regulation, communication skills, problem-solving skills, among others, which are well-known factors to influence SRH and well-being outcomes. Now, our trial took place in two PHCs in the Bekaa, and the goal was to produce an outcome evaluation to determine the effectiveness of SEEK, and also to conduct a process evaluation to determine to what extent is it feasible and acceptable in this community. So as this is a community-based trial, participants were randomly assigned to either an experimental arm or a control arm following their completion of the baseline survey. So basically in the experimental arm, the intervention was delivered to 16 groups over 8 consecutive weeks, with each group attending 1 session per week, whereas the control group didn't attend the sessions, but later on completed the same surveys. So then later, by the end of the intervention, we administered post-intervention surveys for both the control and the intervention arm. And also 3 months later, we administered the same surveys so that we can see if there are any differences between the groups. Another thing you can notice here is that the intervention happened during September and December 2024, which also marks the period where escalations in the war happened in Lebanon. So obviously, this was very challenging to work in this context, but despite that, we maintained our operations with necessary adaptations. So in total, we enrolled 485 participants at baseline, and by the time we got to the endline phase, 30% of them had dropped out, mainly because of war-related factors. So I'll jump now to the results and the findings, but I'll first start with the participant characteristics, just to give you an idea of the sample that we're discussing. So the participants were mostly aged 18 to 22, so the mean age was 20. Most of them had gotten married around the age of 16 and had at least one pregnancy before the age of 18. Only 38% of them reported using like current use of family planning methods, and knowledge of STIs and HIV in specific was extremely low. Now, in terms of its effectiveness, in terms of SEEK's effectiveness, and despite all the challenges and all the war-related disruptions, SEEK was very effective in improving several key outcomes. So, for example, at the endline, participants in the experimental arm, so those who attended the sessions, were 7 times more likely to endorse healthcare providers as their preferred source of information when compared to those who did not attend the sessions or the control group. And this was even sustained 3 months after the intervention. Also, in terms of SRH knowledge, the experimental group were nearly 3 times more likely to correctly identify HIV transmission methods when compared to the control group, and 6 times more likely to identify HIV prevention methods also when compared to the control group. And this was also sustained over time. Our results also showed that well-being scored improved by 3 points at endline and then by 6 points 3 months later. Coping and perceived social support also showed similar results. However, for self-efficacy, while we did observe significant improvements at endline, this was not sustained over the next 3 months, probably because this might require some form of additional follow-up or reinforcement to maintain those gains over time. But taken together, this tells us that those who attended the SEEK sessions, as compared to those who didn't, had better SRH knowledge on selected outcomes, better coping skills, better self-efficacy, stronger support systems, and better overall well-being. Now, with all of that said, there are some outcomes or some key outcomes where we did not observe any significant changes. And those are one, family planning service uptake. And this is likely due to all the barriers that the healthcare system went through during the war, which restricted access to service or restricted maybe the availability of family planning material, and also which may have shifted the priorities during that time. But also another important point here is that it could also be because of the lack of inclusion of male partners in the intervention. Because as we've discussed earlier today, males or the husbands, or also someone else brought up the idea of the family and the neighborhood, and these also play a role in decision-making when it comes to family planning. We also did not observe significant changes on mental health indicators, such as depression, anxiety, emotional regulation. And it's possible that due to pre-existing vulnerabilities, that might be associated with the living conditions of refugees in these communities, and also because of the sustained contextual pressures that were brought about by the war. This could have, impacted this. The last thing is regarding STI symptom reporting. So we also did not observe any changes there, probably because this would require a bit more time to work with and longer follow-up periods. Now, in terms of the process evaluation, which tells us about the implementation process, its feasibility, acceptability, etc., there's a lot to be discussed here. But for the sake of time, I'll only focus on a few critical insights. And I'll start with participant satisfaction, which was very high. So many of the participants reported gaining new practical knowledge that they could apply in their daily lives, as we've also seen from the video early on, which impacted, their relationships with their husbands, with their families, and their communication styles. We also saw a lot of report on participants trusting the paraprofessionals, which this was really a core strength of the project, because participants and paraprofessionals largely shared similar cultural backgrounds, cultural beliefs, which helped the participants to feel heard and understood. And also, based on anecdotal data, we saw that the sessions formed some kind of a support system and a safe space for the participants to learn and to share experiences and to express themselves. So this is also important. However, on this note, the main challenge that we faced with regards to the paraprofessionals was that despite them having a strong technical understanding of the content that they were delivering, they did have a few shortcomings when it comes to their soft skills. So communication and presentation skills, which might require further development and subsequent projects. Another challenge, obviously, was the disruptions caused by the war, which required a lot of contextual awareness and flexibility. So with active conflict disrupting movement in Lebanon, we had to successfully pivot our plans and to train local staff from the targeted communities to support us in leading on the fieldwork and field-related coordination, while our core team monitored the operations remotely and on a daily basis. Of course, we made sure that our areas of interventions were not under threat and that the safety of the staff and the participants was not compromised. Two more points for the process evaluation. One is that field coordination was also very demanding because field staff, which some of them are here with us today, had to consistently reassign participants and reshuffle them into different groups and to organize additional makeup sessions, all of that to ensure that the participation and the engagement of the refugees and to minimize their dropout. They also had to deal with many unforeseen hurdles. They had to do constant daily reminders to the participants, etc. That required a lot of work. Finally, in terms of content delivery, the content and the format was largely praised by the participants for its clarity, relevance, and easy-to-follow format, especially in the way that the topics built up towards more complex discussions. So based on our experience, based on these findings, I will share just a few key lessons learned here. One is that flexibility and conflict sensitivity were vital to safeguarding the intervention during the chaotic time that it was implemented. And so it was very important for us to adapt quickly to what was happening and to act accordingly. Two, involving the community in the delivery and in coordination. So not just in the design and the validation of findings, was also critical to feasibility and to ensure cultural alignment. And third, we learned that rigor and quality can still be maintained in such projects, even in times of conflict, if we adapt quickly and we prioritize safety without compromising on core methodological standards. Because at the end of the day, this is a community-based RCT. And as you know, we had to adhere by strict protocols. In conclusion, we can safely say that SEEK successfully improved key SRH and well-being outcomes, and it was feasible even in times of war. And more importantly, now that SEEK has been tested and evaluated, SEEK has shown strong potential to be scaled and replicated in other settings. Some of our recommendations, I'll leave you with that, are one, to explore the role of including husbands in the intervention. Two, to expand skills training for paraprofessionals. And three, to explore potentially digitalizing the SEEK intervention and the training program. I thank you very much for your attention. I'd be happy to take any questions if you have any. Yes, please.
So for exploring inclusion of husbands in a program like SEEK, so at least in Canada, we have a lot of struggles when it comes to the idea of being able to. We have a lot of struggles in terms of including husbands in similar programs because we found that historically women have been more open to trying something like this. Without something like a financial incentive, without something like that, how do you envision incentivizing husbands to be open to join such a thing that has such a big burden of it's so different from their own patriarchal expectations of themselves, the stigma and everything that comes with it?
Yeah, no, that's a good point, and I think this is a very sensitive issue. We also would expect a lot of resistance from the husbands. But I think, starting with gathering some data on how they would feel about such an intervention, understanding exactly, what kind of obstacles they foresee, what would prevent them from doing that, how do they perceive this whole situation. I think that would be a good start. And then after that, I think it would be good to kind of go along with their preferences to see, what would motivate them to attend as a first step.
And then the second question comes to the idea of you've highlighted the cultural sensitivity, which is fantastic. Obviously, co-developing a program with people for the people that is presenting does build the trust that you talked about. I find it very fascinating that there was such a big cultural divide between like Lebanese people that are being that are presenting this, that you needed, and then like Syrian refugees, that there was the big need for cultural sensitivity. Can you just explain more on like why that was like the biggest like cultural sensitivity challenges, where you felt like if it was just where it felt it was completely necessary. Obviously it is necessary. It's more so. What are the challenges that led you guys to want to incorporate this?
Yeah, thank you for mentioning this. This was one of the points that I wanted to focus a bit more on in the presentation, but I had to keep it short. But since you mentioned this, I think including people from the community to support in delivering the sessions and also in coordinating the sessions was super important. But like one key insight here is that we noticed that these people played some kind of a mediating role between the research team and the participants, and like the research team had really very minimal impact or had a very minimal role in this, like in the whole intervention. We just firstly coordinated the training sessions, and then they went along their way, and they were the ones doing the intervention. We were just overseeing from afar. So yeah, that would be my answer. That it's this aspect is important because these people can play a mediating role, so they understand what's happening in the research project from the technical perspective. They understand our language because they've been with us throughout this whole process. They've attended the trainings. We communicate with them regularly, but at the same time, they are still part of those communities that we are trying to serve. So they had like a very unique position in this project.
Thank you so much.
Yep. Please.
I have a question.
Okay. Since the mic is there.
So thank you for this comprehensive presentation.
Yeah.
Considering the barriers that most refugee women are facing, like mobility, limited mobility, would you consider adapting these sessions into digital delivery, like, I don't know, mobile apps or WhatsApp, in order to reach more refugee women in most settings that are not. Thank you.
Yeah.
In the settings that are isolated, I mean.
Yeah. Thank you for bringing this up, and definitely we are in discussions. And now that we've started, in the phase of closing the project, we're thinking of the next steps, and we are currently in discussions regarding that particular topic, which is how can we start thinking of digitalizing this whole intervention so that we can have larger reach, especially to those populations who live in remote and hard to reach areas. So yeah.
Okay, this is Maggie Ghanem from UNFPA. Thank you for this presentation. I have a few questions and a comment. First of all, I would like to say we all know that the health-seeking behavior is subject to different factors, including the peer pressure and the community. And here I want to know if your intervention took into consideration engagement of community leaders, key influencers, and so on. In terms of the evaluation of the services, and if there has been any improvement in the health-seeking behavior, and since this project is done in close partnership with the Ministry of Public Health, it would be interesting to know if there has been any increase in uptake of services in the PHCs in the catchment area where this project has been implemented. On the other hand, I would like to know why you have touched on HIV, knowing that this is somehow relatively low in incidence and prevalence. And we have seen that the family planning, there is no improvement at this level, if I may say. And here I would like to note that during the crisis, the Ministry of Public Health and the different actors, including UNFPA, made sure that contraceptives are made available at the primary health care center. So they applied a push system so that there is no shortage at the PHC level, and it was following up on this matter, there were no shortage of contraceptives. So in terms of, let's say, availing contraceptives, it was there. So it would be interesting to know about this, and flagging that there has been different initiatives on man engagement in community interventions, and also there are experiences on family engagement as couples in addressing SRH and SRHR, because practically we talk more about SRHR as we look at the well-being, and we bring the GBV context when we talk, we talk about the protection and the health at the same time, specifically among the refugee population. Thank you.
Thank you. I'll try my best to answer all of those questions if my working memory allows me to do so. Okay, so your first question regarding help-seeking behaviors. Yeah, definitely. Community leaders were involved in this process. So, for example, community leaders at the PHC level, but also at the municipality level, they were all informed about the project, etc. So we did not see improvements on that end, as you can see from the findings on family planning service uptake. And it's good that you pointed out that there was no shortage of contraceptives available in the primary healthcare centers. Maybe we needed to do a bit more follow-up interviews with them to really understand what were the reasons for them not to, go along with family planning uptake services to further understand that. In terms of HIV, because as you know, HIV is one of the more severe STIs, and because of their very low baseline knowledge of HIV, that's why we focused specifically on HIV as opposed to other STIs. Did that answer all your questions? Okay. Is there anything else that, yeah. Yeah, definitely. Definitely. In the project, we looked at 3 months post, but of course, that's not long enough to determine behavioral changes over time. Maybe longer follow-up periods would be warranted at this point. Okay, thank you.
Hello, this is Jinan Abiramia from the National Mental Health Program at MOPH. Thank you, Hadi and the team, for presenting this very impressive project. I was very impressed by the small dropout rate, actually, despite the war, so well done on that. One question, actually, I think our colleague asked it now, about the long-term effect. So if there are any plans to follow up on this cohort of this study to see whether there are sustained help-seeking behaviors over 6 months or 12 months. That's one question. The other question is mainly related to if there are any plans that you're considering for the upscale and the continuity of this intervention beyond the research trial. And how much do you think it is feasible to maintain it and how cost effective that would be? Did you look into that as part of the study? Thank you.
Yeah, so to start with your last question, no, we still haven't had any serious conversations about how are we going to upscale it and exactly what the next steps would be or what the direction is. We have some ideas here and there, but nothing concrete yet. So I don't think I'm well positioned right now to answer this question. In terms of the sustained effects over time, as I said earlier, I think it would be interesting if we can, reconnect with the primary healthcare centers and to review their own internal data to see if there has been any changes, because ultimately the refugees that we worked with live within those catchment areas. So they are likely, if they were to seek services, they were likely to go to those PHCs. So it would be interesting to do that. My concern would be that with the new wave of migration and the whole wave of migration that happened during the war and after the war, I think that would make it a bit challenging, but it would be interesting to look at nonetheless. Okay, so I'm being told to stop here. So thank you very much again.
Thank you, Hadi. Now we move to our second panel discussion, from implementation to impact, designing and scaling community-based health interventions for sexual and reproductive health among refugee women. We are pleased to welcome Dr. Tanya Boski as the moderator for this session. Dr. Tanya is an associate professor of clinical psychology at the American University of Beirut and adjunct at the Trinity Center for Global Health. She specializes in social determinants of child and adolescent mental health and psychosocial interventions, addressing the social ecology of children and adolescents. In collaboration with communities, civil society, government, and UN agencies, she has contributed to the development and testing of mental health and psychosocial trainings and interventions, including the telephone-delivered common element treatment approach, the Sawa Aqwa intervention, and the diploma in child and adolescent mental health in a humanitarian settings. Yes. Our speakers and experts for this panel are Dr. Viloshny Jovender, scientist from the Department of Sexual and Reproductive Health and Research from the World Health Organization in Geneva. She's joining online. Dr. Hala Youssef, Regional Sexual and Reproductive Health Advisor from UNFPA Egypt. She's joining online as well. Dr. Gladys Hunain, Associate Professor from the Hariri School of Nursing at AUB Lebanon. And Ms. Lina Sabra, Executive Director at the Lebanese Association for Family Health, Salama, IPPF Lebanon.
Hello, everyone. I'm really delighted to be here and to have been part of the SEEK journey so far. As sexual and reproductive health challenges among refugee women and girls persist, community-based interventions have emerged as essential pathways to increase access, improve outcomes, and promote empowerment. Beyond identifying needs, the real challenge lies in designing interventions that are scalable, that are sustainable and integrated within existing health systems, while ensuring that they remain responsive to the lived experience of refugee women. So this panel will examine effective design and scale-up strategies for community-based sexual and reproductive health, and draw on examples from SEEK and highlighting sustainability, integration into health systems, and the role of local actors. So I will start, as with panel one, I will introduce the first speaker, Dr. Viloshny Govinder, who is a scientist in the Department of Sexual and Reproductive Health and Research in WHO and joins us online, with expertise in health economics and health policy and systems research. She leads a portfolio of activities on sexual and reproductive health and rights in health systems and universal health coverage, including in humanitarian settings. Dr. Viloshny also holds an honorary associate professor post in the Health Economics Unit in University of Cape Town and the School of Nursing and Public Health in University KwaZulu-Natal. So I will ask you the first question, Dr. Viloshny, if I can find it. So drawing on the experience of the SEEK intervention, what key principles should guide the design of community-based sexual and reproductive health interventions for refugee women to ensure that they're both effective and adaptable across context? And a double-barrel question. So the second part, how do we design evidence-based programs that meet international standards, but also are culturally acceptable, practical, and embraced by the local community? Over to you, Dr. Viloshny.
Thank you, Tanya, and good morning, good afternoon, everyone. I'm terribly sorry I couldn't join you today. It's a big regret of mine, but so I think Tanya, before responding to the question, I just would like to just take a moment just to appreciate, on behalf of WHO, but also myself personally, the incredible partnership and the collaboration we've had with GHI, with RHP, with ORA supporting the program, and with the Ministry of Public Health in Lebanon to be part of this incredible initiative. Also want to acknowledge the amazing team at GHI, the Refugee Health Migration Program. Also those like Asma who are responsible for implementing the intervention and the partnership, the participants on the ground who participated despite the challenges which have been well described this morning, and I think by Hadi as well, in terms of adapting to the realities on the ground. And I think also just important to remind ourselves, and again, why WHO is also very much engaged in this collaboration, is that refugee women, adolescent girls continue to face entrenched sexual, reproductive, and mental health challenges. And this is precisely the challenge that SEEK has been attempting to address. And these challenges are compounded by displacement, by trauma, social barriers. And again, this has been very well described this morning, and I think very much appreciated and understood by everyone in the room. And importantly, a theme throughout this morning, and again, I think it's emphasized by Hadi's presentation, is that community-driven approaches are not just ideal. They're absolutely essential, but they must be evidence-based, adaptable, and culturally relevant to truly work. And speaking again and drawing from the experience of SEEK, and I think we will continue to learn from the implementation of SEEK in Lebanon, I think for some time to come. But some of the key principles, I think, which resonate for adapting and implementing even in other contexts. The first is co-design with refugee women, adolescents, right from the start. I mean, I think this was an important integral element of SEEK. In SEEK, this involved embedding community-based participatory research in the program design and also taking into account questions of intersectionality. And I think that was also raised from the audience this morning. And the impact of this has been that refugee women help co-create and implement the program as paraprofessional facilitators and as part of the local women community members. And this also not only ensured building trust and relevance, but also long-term ownership. The second important principle from SEEK has been empowering community paraprofessionals, and this was done through training and employing refugee community members as frontline facilitators. And in terms of SEEK, a low-resource, high-trust model, this also enables potential scalability in fragile settings, where paraprofessionals deliver content in culturally meaningful ways, and also importantly can bridge the gap between communities, the health systems, and the researchers, particularly in SEEK. The importance, another principle, which I think resonates well with SEEK, has been respecting culture without compromising science. And I think this is a point that Hadi also picked up. And this was through designing content that also meets international standards in terms of international global guidance and ethics, but also allows for localization and respectful delivery. And this has been demonstrated in SEEK through where, for instance, direct demonstrations may cause discomfort. The use of visual aids instead can also preserve core messages while honoring community norms. Another important principle, I think, which may not have been fully appreciated right at the beginning of the implementation, but was well, I think, understood during the implementation, and particularly during the war, was to plan for disruption, but also stay flexible. And this required building logistic agility into program delivery. Again, I think Hadi has also described this. What this has done in the context of SEEK is that it enabled adaptation. It shifted leadership to the local teams, modified session timings, ensured where possible safety, and flexibility also ensured keeping the program alive and effective, and also importantly within the timelines. Another important barrier or important principle was removing some of the practical barriers to access. We've heard so often, and importantly, some of the gender norms that can prevent participants, particularly women, girls, from participating. One of the interventions, and again, another adaptability from SEEK, was to offer transport where possible, childcare, flexible scheduling. And this has been important in responding with real world solutions like transport incentives and plans for child-friendly spaces. And it's important to think about as we speak around scaling up. And many of these adaptations, Tanya, are again really possibly feasible when we talk about situations where the funding envelope is increasingly constrained. And lastly, is the question around the curriculum, keeping the curriculum evidence-based but modular and adaptive. Hadi's also spoke about digitizing the curriculum, ensuring that it's more accessible for both paraprofessionals as well. So design with a structure, but that allows for room to adapt to the different contexts. And just a final reflection. I think one of the important reasons why the program has been effective is that it has deeply embedded the lived experiences and the social realities of refugee women and adolescent girls within the program design. And SEEK has also showed that culturally grounded design, the importance of local leadership and adaptive implementation are importantly, they're not trade-offs to scientific rigor, but they're important and critical as enablers. Thanks, Tanya. I hope I didn't take too much of your time. Over to you.
Thank you so much, Dr. Volosny. That was very interesting, and I absolutely agree, especially with your last point there. So I'll move over to Dr. Gladys Hunain, who is completed her Bachelor of Science in Nursing at AUB and Master's in Public Health as well. She obtained her PhD in Health Services Research in 2012 from the Institute of Health Policy Management Evaluation from the University of Toronto, Canada. She's a mixed methods researcher in community and public health, and her research focuses primary care system improvement, colorectal cancer screening, and refugee health. She is a qualitative research consultant with the Clinical Research Institute and the Global Health Institute at AUB. She is a patient advocate affiliated with I2L, and she's the Community Health Initiative leader affiliated with the Scholar Activists for Impact and Learning cluster at AUB. Thank you for joining us. So my question to you is, what does the evidence from SEEK that we have just seen tell us about the effectiveness of community-based models for improving sexual and reproductive health access and outcomes among refugee women? And another double-barrel question. So the second part, how can research better capture and elevate the perspectives of refugee women to ensure interventions are community-driven rather than externally imposed?
Thank you so much. My involvement with the SEEK started way before we started the implementation of the actual learning modules and, the preparation of the paraprofessionals. We actually started back in 2020, if I remember the date exactly. And this is when we started the community engagement. So the first step that we have done, in addition to collecting evidence from the, literature, is we went straight to the communities. So we were really looking to their perspective, and we did interviews with women who are living in informal tent settlements. We did interviews with key stakeholders such as the NGOs who are working on the ground and decision makers in some instances, to get their perspective on what would be the most important and culturally important topic to focus on, because as you know, there are a lot of challenges that are around sexual and reproductive health. So we wanted to get their perspective and also to learn more from the cultural, the issues around the culture. And we, everybody here in the room agrees that cultural issues are very important when it comes to health-seeking behaviors. So we wanted to make sure that we are capturing all those perspectives. And also we asked them what would be the best approach to be able to reach out to women, because, we think differently from what the population wants to have. So we were able to get all these perspectives in mind. And then when we were doing those interviews, and this is very interesting, we were trying to identify the influencers in those communities, because we wanted to have them as, you know, the kind of the mediators between us and the community. And this is how we came up with the local women, whom we call them the community health workers. And we were trying to get also to get them on board when we were preparing for all the modules that came along, and who would be the best, you know, people that we can talk to, and so on and so forth. So that was really community led, and that was really culturally embedded intervention. And we made sure that all our interventions as well, coming to the learning modules, that we tested them on the population. We made sure that everything, and I remember very well that whatever we designed in terms of learning modules, we are trying them or piloting them with the similar population groups that we wanted to implement them on, to make sure that we are not touching on anything which could be culturally inappropriate or incompetent with the population that we're talking with. So we modified the learning modules in such a way to be really addressing the population that we are addressing. So all of those interventions that we have done in preparation for the training and everything helped into making it very kind of embedded into this culture, and we made sure that we are covering all the important issues. That's why we focus on family planning, and that came up from the you know, preparation that we have done. We focused on STIs, sexually transmitted infections, and also mental health. And the fusion between the two made it so kind of appealing to the woman, because they came not only to learn about sexual and reproductive health, but also on life skills. So how to talk to the partner, how to deal with the conflict, how to relax yourself and regulate your emotions. All of those are not only for sexual and reproductive health, it's for everyday's life. So this was a very important intervention that is really culturally embedded and also community-led. That was an excellent experience. And I must say that the team who's been working on all of those issues has done a wonderful job to being robust and methodologically correct. And they're capturing everything and documenting it in such a way to be able to measure the evidence eventually. And that's what came up, you know, from the presentation, today's presentation by Hadi, and, you know, what we talked about. So this is in a nutshell what I can say about this project. Thank you.
Thank you so much. It's wonderful to hear your reflections. I will move over to Dr. Hala Youssef, who is currently working with the UNFPA Arab States Office in Cairo as the Regional Sexual and Reproductive Health Advisor. She also held the position of the Population and Development Advisor at ASRO between 2017 and 2022. In 2013-14, Professor Youssef held the position of Director of the Egyptian National Population Council, leading on the National Egyptian Strategy for Population and Development. In 2014, she was a member of the Advisory Council on Community Development to the President of Egypt, and in 2015, she was appointed as the Minister of State for Population in Egypt. Dr. Hala enriched her expertise through working as a professor, mentor, and a researcher on population and sexual and reproductive health studies with renowned publications at both national and international levels. Thank you for joining us. Dr. Youssef, my question to you is, how does UNFPA view the role of community-centered programming in addressing sexual and reproductive health gaps, and what support mechanisms are most critical for scaling up? Over to you.
Thank you very much. I'm Tanya for your moderation and the introduction. I'm very happy to be part of this panel. And actually, I do thank AUB for inviting me. Also, I want to thank everyone who contributed to this SEEK project. It's really a very important piece of research and intervention at the same time. So I really acknowledge all that. Actually, I work now for UNFPA, which is the Reproductive Health Agency for Women and Girls. And I was very happy to see Maggie in the room. She is our sexual reproductive health specialist in UNFPA country office in Lebanon. So thank you, Maggie, for being part of this discussion, which is very important. And I want to thank the office for all the work they're doing in Lebanon for women and girls. Actually, UNFPA sees the community-centered programming as an essential part of addressing SRH gaps through many channels or entry points. One of the very important points is demand creation. And I'll stop here, and I think it's very important, demand creation. And before going into the examples that UNFPA is doing, I want to go back to 2018, 2019, when UNFPA had a similar study with mixed migrants in different countries. And though they're not refugees, but still they are on the move, they have challenges, they have stresses that really impedes their access to sexual reproductive health services and information. So at that time, the results were very similar to what came out of SEEK. They had low interest in family planning. They had no interest actually in sexual reproductive health services. They were very different in terms of their priorities. So putting people at the center and thinking of what are their priorities and how to create the demand of such an important part of their life, which is sexual reproductive health, is very important. So while community health activists and mobile teams do expand outreach services, still also we want to focus on community midwives and mobile SRH teams that play a crucial role in sharing relevant information and increasing access to quality services. At times, and especially in conflict, putting the population movement into the focus is limited by many issues like insecurities, lack of finances, and hence giving them the information and create the demand is vital. There might be also some linguistic barriers that between refugee populations and service providers that needs to be bridged by community-based approaches. So there are many issues to consider in demand creation and put it on the top of needs. Actually, culturally appropriate and accessible service provision is important and critical in humanitarian settings, especially in Lebanon, Jordan. We have many examples. For example, in Lebanon, community midwives and mobile health teams have proven very effective in reaching individuals facing mobility or financial barriers and whatever. Also, we have initiated in Zaatari camp in Jordan, maternity clinic and supported the delivery of 15,000 babies there. So without a single maternal death, which is very important for definitely sexual reproductive health and the sustainable development goals that we're working on and working within a very politically unstable region that requires a lot of attention and work. Actually, we have also the women and girls safe spaces. Though this works very good in development settings, but yet it's very important to consider specifically that SRH is very linked to GBV and gender-based violence, and the linkages between both needs to be addressed at the same time, considered in the safe spaces. And in our communities in the Arab region, we always refer to safe spaces for boys and men, but having them for women and girls is very important when tackling sexual reproductive health. On the other hand, the health systems need to be strengthened, and For this, for example, having data strengthened, like for maternal mortality, for MPDSR, maternal perinatal death surveillance and response. This is very important. So when national systems break, we have a problem with the data, and it's important also in delivering the service and reaching out to communities. The support mechanisms are critical to scale the improvement of access to sexual reproductive health through engagement of community health workers. My distinguished panelists have mentioned that, and I want to thank Hadi for his presentation on the SEEK, which tackled many important points. The integrated user-friendly service delivery model is very important. And I go back to the digitalization. Back to the study that we had in 2018, 2019, we thought that to make people access knowledge and information, we need to work on applications and reach the people through digitalization. But at that time, internet connections were not that easy. But now with the advancement in digitalization, I think we should be crossing the barriers that we have met earlier. Localization of the work and working with community-based organizations is a measure to ensure sustainability and evidence, and also funding and resources. We have a diminished funding future and we need to work on that, and through working on the systems inside countries and with governments and with innovative approaches for financing, I think sexual reproductive health services can be much more tackled and at the front. And of course, I won't forget the data systems and analysis that has to be continuously done in order to sharpen and modify our interventions to best suit the communities.
I will move on to our last but not least speaker, Selina Sabra, who is the Executive Director of the Lebanese Association for Family Health, Salama, association member of the International Planned Parenthood Federation, and she holds a master's degree in social studies and brings over 20 years of experience in sexual and reproductive health and rights, gender equality, and youth empowerment. Ms. Lena began her career as a youth volunteer in 2000 and was later elected as the Arab World Youth Representative to the IPPF Governing Council. She held multiple leadership roles at the Arab World Regional Office between 2005 and 2013, focusing on SRHR, youth-friendly services, comprehensive sexuality education, and engaging men in SRHR. As Executive Director of Salama, Lena has, since 2013, driven the organization's efforts to deliver high-quality SRHR services in response to Lebanon's ongoing humanitarian and health challenges, especially among refugees, underserved communities, and vulnerable populations. She has also served on the board of the LANA Network, the Lebanese AIDS Network Association, and is president of the Men Engage Lebanon Network's General Secretariat. Thank you for joining. So my question to you to start is, from a local implementation perspective, what are the main challenges and successes encountered when delivering SRH services to refugee communities? And what are the enablers and barriers to sustaining SRH interventions once humanitarian funding cycles end?
Thank you. Hello, everybody. So as Salama, as an association working in the field, we are facing increased challenges under our humanitarian work. When we started working in humanitarian settings, we started working with Syrian refugees. Then we noticed that we have to also work with the host communities, because the host communities need also help and services, and they struggle a lot of challenges. After that, the last months, we faced the war, and we faced challenges in serving the IDPs, the internationally displaced people, or the crisis affected people if they are not displaced. So these challenges are increasing. In any case, the main challenge for all of us as sexual and reproductive health actors is that sexual and reproductive health is not a priority in humanitarian settings. But for us, it's a life savings. So not all the fundings are coming for sexual and reproductive health. In any case, we are facing with all these groups of people affected by the crisis or living in humanitarian settings, the cultural sensitive and stigma. We have the social norms, cultural barriers. The access for the services. They lack transportation, or they don't know where to seek services, or even they don't know that the SRH is critical for their health. And some of them, they don't have documents, legal documents to seek services, or they fear from the stigma or discrimination in the health facilities. We are not a primary health care center, but we are specialized in sexual and reproductive health, but we are working under the Ministry of Public Health as a dispensary. Also, we faced the short-term funding in humanitarian. The funding are short-term, and not all. We have different projects, and not all of the donors are funding the holistic approach. If I want to see the package, the comprehensive package of sexual and reproductive health. So that's why in some cases we are not providing all the services under some projects. Also, we have problems, as the colleagues mentioned, with the referral pathways. There is some problems with this. We are trying to do more efforts, but it's still unclear in some cases. And the limited mental health and psychosocial support integration in the sexual and reproductive health, especially that we know that the people affected by crisis, they face trauma or GBV, so they need mental health services. And now we have this cut of funding. We all struggle of this. So now we have to do more with less. We have to work more with less resources. And in the same time, the needs are increasing. And we need to work more. Our successes, if we want to talk about successes, we have only 2 clinics in Bekaa Governorate. So our success is in Bekaa. We are, as IPPF, we are implementing the client-centered approach. So, which means that quality must be holistic. Quality SRH must be holistic. That's why last year we have integrated in our services the mental health and GBV case management with the support of UNFPA, and we thank UNFPA because they are helping us in providing the services in Bekaa. We were providing this through referrer, but now we are integrating them at our clinics. This is one of our successes. The partnership with the other NGOs at the local level and also at the international level, our membership in different clusters and networks, it helps us also to build a kind of referrer to other services that we are not providing directly at our clinics. Also, our work under the Ministry of Public Health, so we receive from the the ministry contraceptives and condoms, and also our partnerships with IOM and the networks working on HIV. So we receive also condoms for STIs and HIV programs, and also VCT tests. The capacity building for our service provider and youth volunteers. At Salama, we have a general assembly. We have a largest network of peer educators, youth peer educators. We are training them with the staff on everything related to sexual and reproductive health. So they are implementing the projects with us. And also the men engagement in a humanitarian setting. So we are not, when we talk about the humanitarian settings, always we talk about providing services for women. But no, we have also to provide services for men, even young men or men. So we are providing services for men. In camps, at our clinics. That's why we have to engage men in sexual and reproductive health. We have introduced urologists in our clinics to attract the men to come and seek services. Also, we have engaged the targeted community. In one of our projects, we have trained Syrian youth peer educators to help us in providing comprehensive sexuality education for youth Syrian refugees in the camps, because they are a key point for us to enter the camps and to be more closer to the Syrian refugees. So these are most of our successes. And also, yes, the most important point that we are all talking about it is the community-based outreach. So we have mobile units. We are providing services to the people in hard-to-reach areas and the underserved populations in the rural areas. I'm talking about Bekaa only. I'm not talking about all Lebanon. Yes, we are trying to provide to go to the beneficiaries to provide them the services. For example, the postnatal care is not in the culture of our beneficiaries. That's why we have some programs, small programs with our midwives, our volunteers midwives to provide postnatal care through home visits. Yes, and these are most of the successes. What are the enablers? Working with partners at the national level and international level to amplify voices and strengthen advocacy and resource mobilizations to fund projects in Lebanon. Working with the grassroots actors, also it's a key point to reach more people with municipalities. We are working also with the schools, universities, orphanages in Bekaa, and we are providing the awareness sessions for all the groups of the population. I didn't talk about digital health. We are now providing telemedicine in some cases. We started it since the COVID-19. And during the war also, we have strengthened this approach. We have also introduced the self-care. We are providing HIV self-testing for the beneficiaries. And also from the enables is this membership in different networks. This help us to submit proposals with other clusters and NGOs, also coordinating and collaborating with the private sectors in some cases. For example, to buy dignity kits or pads, or to distribute pads during our, with Sanita, for example, during our awareness sessions for young people or young girls. And for us as Salama, one of our enablers is being a member of the IPPF. Because being a member of the IPPF with all the accreditation standards and policies and strategies, this make the donors trusting us and funding us. Yes, and this is
Yes,
the barriers.
Comprehensive answer.
The
You
barriers.
want to add a few things, just
Yeah,
a couple of minutes,
some it's the funding always. In some cases, the refer pathways and the challenges. But what we should do under the humanitarian crisis is to work with the local NGOs as if they are actors. And co-leaders, not only implementing partners, and to give them the role to let them participate in the decision making and the planning of projects. Yes, so to move from the short-term crisis response to a long-term development strategies.
Thank you so much for that really comprehensive answer. Thank you. I think for time we want to make sure that the audience have a chance to ask questions. So we will open the floor for any questions from the audience. Yeah, we have one here.
Hello, this is Lena Spati. I'm as a public health practitioner. So I've worked in the Syrian context in Northwest Syria for like 1.5 years as an epidemiologist. It's very interesting to see that the findings that the SEEK project found is it's very similar to those that are within the internally displaced population in Northwest Syria. So even this is for maybe Dr. Hadi, that so these are more cultural characteristics that are shared within the Syrian culture in general, disregarding if they are based in Lebanon or Syria, if they are refugees or internally displaced. So especially for the uptake of the contraceptive method, it was really interesting to see that they are almost the same numbers. So it's just like maybe as a shared experience that maybe we need to look more in depth if we need to kind of change the health-seeking behaviors, to look more into the in-depth cultures and to see what would affect the change of these behaviors. And definitely the shared experience from different contexts, and different maybe refugees population in different regional countries like Jordan, Egypt, and Syria itself. So it would be very helpful. So it was just a remark, not a question. So thank you.
Thank you for that comment. We have another question here. Does anyone want to add anything to this comment? Yeah, go ahead.
Well, thank you so much for bringing up this subject of cultural impact on family planning adoption. If I may add, when we were also kind of asking the women whether they would be interested in reducing the number of kids that they would like to have, the other thing that, and I think this can be something that we need to be exploring on the long run, is yes, there are cultural demands for having children, but also there are the socioeconomic factors. So a lot of women were pointing that due to the economic situation, they can't afford to have more children. So this was an incentive for them to kind of control the number of kids and to use family planning. So there are some kind of changes in the culture that are adaptable to the situation that's happening, but it's going to take a lot of time given the circumstances. Thank you so much for bringing up this subject.
Okay, hello again.
I'm trying to ask this question from a holistic perspective, not specifically to this panel. Okay, so what next? From an advocacy perspective, okay, you're not the first one working on SRHR, you're not the last one. We have a lot of interventions, but from an advocacy perspective, what are you gonna do? Are you gonna push for policy reform? Are you gonna use your data for public awareness sessions? Are you gonna mobilize communities? Do you have a future plan or just another needs assessment, statistics displaying, and that's it? So from an advocacy perspective, from a rights perspective, so if we're gonna talk about long-term impact, what are you gonna do?
Thank you for that question. I think it raises the frustration of doing research that doesn't necessarily lead to impact or that isn't scaled, and I can hear your frustration in that system. Does anybody want to answer that, Dr. Volosny, maybe, or even Hadi? I don't know if you want to jump in. Yeah, go ahead. Yeah.
Absolutely. Sustainability is an issue. And as Hadi mentioned that, we don't have a real clear plan for continuity, but definitely the results and also the SEEK itself, how it's been implemented is such an important advocacy tool that should and we need to be pushing the agenda to get more funding for the subsequent step. Definitely that. But the most important thing is a lot of organizations, and including our intervention, are using local community health workers. And as we know in Lebanon, it's not institutionalized. It's like very fragmented. A lot of organizations are using it. If we really need to be continuing with this approach of community engage, we need to institutionalize those local community health workers. We need to create a framework for where they're going to be working, their roles and responsibilities. At the same time, how we're going to be subsidizing them. So far, we've been doing it on volunteer basis, but if we have to think about the funding mechanism and so on, this is the only way to get to the people. SEEK as an example, but we do have a lot of other issues that we can use the local community health workers.
Go ahead, Dr. Roshni.
No, just to say, I think that was an excellent question, and I think that's really part of the intention of this event today, is to think beyond SEEK and how it can be institutionalized. I think the question around partnerships, I think that Ms. Lena spoke about, I think, and again, we have UNFPA in the room. We had our colleague, Dr. Woodman from UNHCR earlier. And I think the whole design of SEEK, of course, I'm speaking from WHO in Geneva. I've not been on the ground, but been very close to the discussions. Also has included very closely the Ministry of Public Health as a key partner, embedded the interventions within the primary healthcare centers. So these are all opportunities and kind of forward thinking in terms of how the project or how the intervention can be embedded within the wider health system, recognizing some of the resource constraints within the on the ground, but also engaging all partners, both local and international, from the start. So back to you, Tanya. I hope that in some ways a very kind of a top-heavy response, but I hope I think it does resonate with the implementation of SEEK.
Okay. Yeah. So I'll just also add a quick answer to your question, which is obviously an important question. But I think at this point we have a proof of concept. Okay, so we know what aspects of SEEK work, what aspects don't work, and we know how SEEK can improve the outcomes that we're interested in. The next step, as my colleagues described now, is to think of, okay, how can we scale it up, institutionalize it, and roll it out so that we can reach more people and have a better impact on SRH related outcomes in these communities.
Thank you so much for all of your comments. And if I could also just add with my researcher hat, not moderator hat, that there's a very big shift also within academia and within research from effectiveness studies and needs assessments towards implementation science. So it's slow, but it's recognized now even within the research community that we need to shift our attention to pathways to scale and pathways to impact. So thank you for the question. Yeah, of course.
I think what's important as well is to do a cost-benefit analysis so that we can prove like we are really saving on money and getting better outcomes. This would be an amazing contribution to how we can change a little bit the perspective on how to use the local communities as well.
Thank you for that. Other questions or comments? And thank you so much, everyone. Thank you to the panelists. Thank you.
Well, in the light of our current discussion and since digital health solutions for sexual and reproductive health are being promising solutions, we'd like to bring to your attention that we at the Global Health Institute will be offering next week an online synchronous course on digital health and AI solutions tailored for low resource settings. So if you have any question regarding this, you can reach out to me and to my colleagues in the lunch break. And this brings our event to an end. Thank you all for your participation and attendance, and please feel free to join us in the lunch break. Thank you. Okay, and if you want to scan and to know more about the course, just scan this QR on the screen and let us know.